Hello, everyone. My name is Virginia Kaklamani, and I have the pleasure to have with me today Dr. Sherene Loi. Welcome, Sherene.
Hi, everyone.
So we've seen data in the past several years on TNBC and immunotherapy. Now we have data on ER-positive early-stage breast cancer and immunotherapy. Summarize it for me and tell me how do you interpret all that data?
Yeah, so I think the data is a little bit surprising, but very encouraging for patients with HR-positive breast cancer. So the 7FL and also the Keynote 756 studies looked at a population of HR-positive breast cancer that were high grade, so they had to be grade 3 by local pathology or central pathology, and positive for ER, and gave them neoadjuvant chemotherapy, and then looked at the benefit of nivolumab, checkmate 7FL, or pembrolizumab. And both studies were positive in the overall population, but most importantly, there was a subset of patients, PD-L1 positive or high immune infiltrated, or interestingly, lower levels of estrogen receptor status and low PR, which seemed to derive a lot of extra benefit from the addition of nivolumab. And the PCR rates I felt were quite impressive, and especially in the context of these patients historically doing quite poorly on our current standard of care. So I think the data strongly suggests that the addition of immunotherapy for these patients can be highly beneficial for their long-term outcomes, given the very high PCR rates. And we know that patients who achieve a PCR do really well long-term, even in the HR-positive population. So I think the data were quite compelling.
So there was a discrepancy between the early stage TNBC and the early stage HR positive as far as PD-L1.
Yes.
And I know you presented a lot of the different PD-L1 stains here at San Antonio, but how do you interpret the difference where PD-L1 seems to matter in HR positive, but maybe not as much in TNBC?
Yeah, so I think I have a few theories on that, but I think the bottom line is the PD-L1 assays, as we know them at the moment, are just not sensitive enough in triple negative breast cancer. In other words, a PD-L1 negative assay score in TNBC does not actually mean it's negative. So we know that the majority, 99% of patients, have a degree of immune infiltration. So I think pembrolizumab is really boosting pretty much every patient with early stage TNBC. In contrast, in HR positive patients, this is only a subset of patients that have the biology that generates an immune response. So I think it's clearer there because it's not as frequent. And potentially, as I mentioned as well, TNBC is very heterogeneous. So a core biopsy can potentially miss any degree of PD-L1 positivity. So I think there are a number of reasons there, but TNBC in general is more immunogenic and more immune infiltrated. So on the whole, more likely to benefit from immunotherapies than HR positive disease.
And so maybe your assumption could be that if we have all of these immune assays that look like to be more sensitive than PD-L1, that's where maybe we could see more difference even in TNBC?
Yeah, I think so. I mean, I think it's how we want to use an assay. So if we use the analogy of HER2 and Receptor, we really want to just identify the patients that don't benefit, right? So I'm not sure if we want a little bit of benefit or a lot of benefit, but we really want the patients that are not going to benefit. So maybe till like less than 1% is going to be a better assay than PD-L1, which where you have a big grey area. So I'm kind of leaning towards an assay which has high negative predictive value than an assay that's sensitive.
Okay. And so obviously we don't have EFS results yet. We just have PCR. But how would you think of these results going into clinic on Monday? Who's the patient with HR positive disease that you would consider giving IO to?
Yeah, so that's a really good question. And obviously, to be cautious, we have to say we have to wait for long-term data. But I think we all feel that patients, particularly those with lower ER expression, so in the 7FL, less than 50%, but certainly less than 10%, lower PR expression, less than 10%, these patients are behaving like triple negative breast cancer. And certainly the data in both Checkmate 7FL and Keynote 756 suggest that the addition of immunotherapy is similar for those patients and than what we see in triple negative breast cancer. So, I would be highly tempted in these patients when I see them on Monday morning, high grade, lower ER, PR expression, and a degree of immune infiltration. I mean, the PCR rates are like 60, 70% in some patients, right? I mean, double what we normally see in your classical HR positive breast cancer. So, I think the data are quite compelling. Hopefully we'll have long-term data really soon.
And would you test PD-L1 in this patient population to decide on immunotherapy?
So I think ER/PR is very compelling. But I also think that just looking for stromal till, and you can do this using light microscopy. Stromal till is now, there's a CME accredited course on the FDA website. We have a website. Any degree of immune infiltration, simply looking at down the light microscope will tell you if these patients could potentially benefit from the addition of immunotherapy. So I don't think we need anything as fancy as PD-L1 in these patients as yet. And potentially with PD-L1, you could be missing a whole lot of patients.
No. Perfect. Well, thank you so much for being with us. I hope you all enjoyed it, and see you next time.
Bye.